And in the afternoon also, we are going to have a session on this particular aspect in much more detailed length. So what we are going to see here is few definitions, and the definition is that why we should be talking of Mayfield. Junior audience, what is Mayfield? Metabolic dysfunction associated fatty liver disease. Fine? So this is previously taken as Mayfield. And what is Mayfield, by the way? It's just the deposition of fat, or is it the cardiovascular risk factor, or mainly the combination of two? Is it? क्या है? कोई तो जवाब दे. जूनियर ऑडियंस जो लास्ट में बैठी है, हमारे कुछ पोस्ट ग्रेजुएट पे नजर आ रहे हैं. It's a combination. Okay, we are going to see that. So why we should be doing discussion on Mayfield? Most common liver disease. पाकिस्तान में most common liver disease क्या है? Infective or non-infective? NCD या CD? Communicable disease या non-communicable disease? It's a communicable disease. Which disease is it? Hepatitis C. ठीक है, लेकिन अब अगर वर्ल्ड का डाटा लें, ये नीचे मैंने रेफरेंस अपना नहीं रखा है. This is the most esteemed reference that you can find in this subject of Mayfield, a Muslim person. Zubair Muhammad Yunusi is one of those who are there in the US guiding a guideline for Mayfield and MASH and other. So you can see that this is the most common liver disease. It is the second most reason for liver transplant, particularly under the age of 50, and a leading predisposing factor for primary liver cancer and net cancer occur even in the absence of cirrhosis. Which other communicable disease can have cancer, liver cancer, in the absence of cirrhosis? Communicable cause, in the absence of cirrhosis, the liver cancer does it produce? Hepatitis B. So it's actually one of those things that you see. The most toxic carcinogen is tobacco. The second most toxic carcinogen is hepatitis B. And now we are seeing an emerging sort of a thing where Mayfield act without cirrhosis leading to liver cancer. This is something that people need to understand. Then finally, what we can see is, ये कुछ है इसके साथ. So what we can see, majority of people with the Mayfield have got normal liver enzyme. ये एक बहुत important point है to understand. 50% of them, they are not having liver enzyme deranged. So this is again a unicality for Mayfield. And that usually occur with Hep B, Hep C. Hep B or C? Mainly both, particularly C. So these are the few things that are common. What's the cirrhosis difference between a patient having Mayfield-related cirrhosis and a viral etiology-related cirrhosis? They usually do not got in early phases the ascites. So people got cirrhosis with some portal hypertension, absence of ascites. These are the other characteristics only akin to Mayfield-related liver disease. Then, what is the schema that has been given in Hepatology 2024? The metabolic liver disease, actually, the cirrhotic liver disease has been first labeled as Mayfield. This is equal to Mayfield. Now, Mayfield has been, or Mayfield has been divided into two. The first is the Mayfield. Mayfield actually having only one risk factor. Liver with the leaden fat, only one cardiovascular risk factor or metabolic dysfunction risk factor, only one is Mayfield. And if you got more than 3 with inflammation, this is MASH. So you need to know that. Then the second is the cirrhotic liver disease, the fatty liver disease has got Mayfield with MAT ALD. What is MAT ALD? MAT ALD is having metabolic dysfunction with alcoholic liver disease. So Mayfield, if the limited alcohol intake, 20 gram and 30 gram female and male respectively per day, that amounts to 140 or 210 gram of alcohol per week, become more, then it converts itself into ALD, which is alcoholic liver disease. So this area is the gray area where the Mayfield combined with the ALD. So these are the second point. The third is purely alcoholic associated liver disease. The fourth is there are other cirrhotic disease which are having fat in the liver but not considered as Mayfield. वो क्या हैं? Drug-induced liver injury, monogenic diseases, particularly there are some enzyme deficiencies, and there may be some cryptogenic steatotic liver disease. So this has been classified, the steatotic liver disease being classified like such recently. How to manage it? That include a multidisciplinary approach. And where the multidisciplinary approach comes from primary care provider, endocrinologist, as we are discussing today since morning, then the patient need a nutritionist or dietitian, clinical dietitian with lifestyle intervention that he or she need to detail to the patient. Then you may need gastroenterologist, hepatologist, which we are already having and sitting together today. And then in between the lines, you may need at time a cardiologist. You may need people with weight management measures to take care of, and health psychologists also to take care of these individuals as a whole. So it's basically a multidisciplinary approach that you need. You cannot manage alone in sitting in your clinic the whole spectrum of this particular disease. Then, if you talk about an overview of pathogenesis and therapeutics, you can see that diet and lifestyle modification, you cannot change genetics, you cannot select your mother and father, but you do got evaluation of those things in the history by the physician of yours. Then you got epigenetic factors. Do you understand, the junior audience, the epigenetic factors? Epigenetics क्या होते हैं? Anything in epigenetics that you can say? What is genetics? It is the gene that you carry from your mother and father. What is epigenetic? Gene affect phenotype, the clinical presentation. When the phenotype affect the genes, that is epigenetics. The internal displacement, war, famine, all these things affect the expression of the disease. So epigenetic factors, microbiome, metabolic factors, all those need to be addressed, number one. And then you got different drugs acting on a different thing to give us some benefit. Particularly of interest, me and Dr. Javed Akram Saab has shared the same slide together. We got a recently available drug, which is resmetirom, and that actually affects the mitochondrial biogenesis. It decreases the crux or corrupted mitochondria by autophagy. Mitophagy, the word is increase fatty acid beta oxidation to decrease burning of already existing fat in the liver. It increases the lipophagy by the macrophages within the liver. It decreases the lipid droplet assembly. It increases the cholesterol catabolism, not the metabolism, but catabolism. So finally, it boils down to increase mitochondrial function, but better mitochondria, not corrupt mitochondria. And that is lipid corrupted mitochondria को autophagy करके mitophagy में ले गए और जो नए अच्छे mitochondria हैं वो evolve कराए. It decreases the intrahepatic triglyceride, it decreases the lipotoxicity, and then finally it may lead to decreased steatohepatitis and fibrosis. आपको लगता होगा एक आध मिनट एक्स्ट्रा, ठीक है? आपको लगता होगा कि यही मोड ऑफ एक्शन तकरीबन लिवर पे किस चीज का है? There are other drugs. What are the other drugs for having fatty liver disease to be treated? Drugs, not lifestyle interventions. कौन सी दवाएं हैं? आप कहें सस्ती दवाओं के नाम लें सर. SGLT2 inhibitors हैं, ठीक? GLP1 receptor agonist हैं. So GLP1 receptor agonist जो है वो क्या करते हैं actually? Does they decreases the fibrosis in the liver? The answer is no, except tirzepatide. They actually decreases the inflammation in the liver. This drug actually decreases not only inflammation, but decreases the fibrosis. So there are GLP-1 intra-group differences. One is the tirzepatide, the rest does actually decreases the inflammation. That does not decrease the fibrosis. They do not harm the liver. In fact, they do not increase the fibrosis, but they decrease the inflammatory part of the process. This drug actually not only decreases the inflammatory part, but also decreases the fibrosis. So resmetirom peak life concentration is 2 to 4 hours. Plasma binding is nearly all is plasma binded, 99%. It is metabolized by cytochrome P450 enzyme system. It has got the half-life of 4.5 hours. Excretion is mainly by the gut, nearly 70%, and only less than 30% is being through urine. Then, this is the important point. The important point is the last point. No meal dependency. So you can take it with or without. So if somebody is being placed on that drug, what to take care of? The first thing before you put the patient is hepatic function, thyroid function, lipid profile, and a non-invasive measurement of liver stiffness. This is what you need to do, because this is probably not available, to my knowledge, in our settings. Once somebody is being put on that, what you need to do at 3rd month to make out liver function, thyroid function, lipid profile, and non-invasive evaluation is not there in the literature at 3rd month to do as guideline. This is from the American guideline, published in Hepatology 2024. At 6th month, you do hepatic panel, again, you do thyroid function, you do lipid profile, and again, there is no mention of 6-month evaluation of non-invasive measurement of liver stiffness. But at 12 months, you do nearly everything again, just like the baseline, and really see whether your patient is getting any benefit or not. If not, stop therapy at 12 months. So, there are trials. One is known as Mastro-Neufeld trial. I'm not going to go into detail. Mastro-Nash trial. And there are trials known as Nash, Mastro-Nash end organ damage evaluation trial. You see the interim results. This is what the interim result for MASH resolution. What is MASH? Metabolic dysfunction associated steatohepatitis and fibrosis improvement. 30% improvement has been seen in 1 year observation. Just see the result, which the trials are of 5 years. They are still ongoing. And this is the interim result. And these results actually led the FDA to put this drug into fast processing, and then they allowed this drug to be there in last April as one of the FDA-approved drugs for fatty liver disease. So 30%, 1/3 of the patient with MASH and fibrosis, there is an improvement. Then there is a 47% fat reduction by non-invasive test results. Nearly a quarter of the patient, not third of the patient, they have got fibrosis reversal or no fibrosis progression at least on this drug after 1 year of therapy. This is not the final result, this is the interim result of the drug. Please take into consideration. Then there are other benefits like lipid benefit, liver enzyme settlement benefit of using the drug. The LDL-C reduction with different doses, 80 milligram and 100 milligram of the dose. Similarly, the apolipoprotein B reduction around 17% and around 20% in terms of 80 and 100 milligram of doses. Triglyceride reduction, so you got the benefit of reducing the metabolic risk factors for the liver disease and in gross diabetes and other metabolic dysfunction. ALT, 1/4, nearly 1/3 of individual in different doses, 80 and 100, they got the ALT settlement, AST settlement, and hepatic fat reduction in nearly 1/3 or nearly half of 80 and 100 milligram doses respectively in 1 year trial, 1 year duration. This is something. And then finally, you can see there are few things that are needed to be taken into consideration when you use this drug, that is drug-drug interaction. And particularly of interest to mine and nearly all would be the interaction for CYP2C8 inhibitors like clopidogrel usage. Here the resmetirom levels get increased, so there is an adjustment of dose of resmetirom. And then statins, particularly rosuvastatin and atorvastatin, these are the two statins that we use commonly. And the dose of the statin, it get increased when you combine resmetirom with statins. So the statin levels once increased, the dose adjustment for statin has to be there. Thyroid hormone, since it is a thyroid hormone beta receptor agonist, so the thyroid hormone levothyroxine needs really to be monitored and may increase slightly, so monitoring is definitely needed. With that, I think the contraindication should also be taken into consideration. One is severe liver disease with child poor class C, Second, there is no trial, no data available for pregnant and lactating ladies. Resmetirom in decompensated liver disease at the moment has not been studied. And then finally, with thanks, strong CYP2C8 like gemfibrozil should not be used along with it. With that, thank you very much.